Yeah. Well, other than that, so now, this is 85 more.
2. Yeah, 1, 2. Yeah, 1, 2. Yeah, are you happy? Gonna be letting mic as well, yeah? I'm sending you pray. Yeah. Yeah. 1, 2. Yeah. 1, 2. Yeah. It's too loud. Yeah. 1. Yeah. 1, 2. Yeah. 1. It's distorting. Can you try it? Yeah. 1, 2. Yeah. 1, 2. Yeah. 1, 2. Yeah. 1, 2. Can you try to record again? Yeah. 1, 2. Yeah. 1, 2. Yeah. 1, 2. Yeah. 1, 2. It's fine. Okay.
Ah, det går det. Just like me.
Good morning, Honourable Minister of Health, Dr. Motsoaledi, the Director General of Health, Ms. Malebana Precious Matsotso, members from the Department of Health that are present here today, members of the Vodacom team. I'd like to wish you a very warm welcome to this morning's media conference on the Stock Visibility Solution partnership that we've entered into with the Department of Health. As the Minister and I were recalling briefly this morning, we started a conversation in his office in 2013, January, around how, as a technology player in this country, Vodacom can assist the Ministry with some of their key health challenges that they have, and how do they see technology playing a role in assisting in having a transformational impact on the health sector. And the Minister threw two challenges to us, one of which was the visibility around stock levels in the primary healthcare facilities in the country. So today there are in excess of 3,100 facilities in South Africa, and the solution we're going to talk about today is a solution showing how a public-private partnership can be very, very successful if there's a meeting of minds in what we as Vodacom could do to support our country and our government, and in particular the health sector, in meeting some of its challenges as it rolls out its health services. On that note, I think I'd just like to say that this partnership has really evolved over the last 3 years, and we're very pleased to say that today the in excess of 3,100 clinics or primary healthcare facilities in South Africa have had the solution implemented. And of course it's early days, and the implementation has taken place over a 18-month to 2-year period, and it's been a staggered rollout. We started off with the Vodacom Foundation being very, very involved in rolling out the solution to the much needed areas, starting in KZN and moving across the country. And we now believe that we have a very strong partnership, and the solution will be a sustainable solution going forward, and I think something that's seen to be very viable and workable in South Africa. And of course this will take time for it to embed itself in a manner that we'd like to see, but we do believe that the solution will meet the needs of the Department of Health. On that note, I'd like to call on Ms. Matsotso, our Director General of Health, to come on stage and briefly talk about the partnership, but also introduce us to the Minister. Ms. Matsotso.
Good morning. I would like to take this opportunity to thank first the Minister of Health for his vision, but maybe to tell you a story before we start. I'm still surprised that I've got a job today, because the Minister has constantly said, why is it that every time I hear that there's no medicine, I see it as a headline in the newspaper? How come that we do not have a system, an early warning system, that tells us about the stock situation? And I think that was an early warning for us. And I met with the Vodacom team. I remember after this meeting, because the Minister decided he was going to find the solution himself. And I'm pleased to say that it is actually humbling that as we're trying to find these solutions, we also had an opportunity to engage partners, both a civil society, I would call MSH, which subsequently changed its name to SIAP, as an NGO that has expertise in dealing with the access to medicines issues. But I also want to say that we've also used MSH in the past to investigate what the problems were in the whole supply chain. But of course, most of you may only know about the reports that are released by civil society. But it was perhaps, maybe, the minister that put us on our toes, but that also took leadership to find solutions. Purely because the Minister of Health may not be an IT expert, but he has passion for apps, and he has passion for information technology as a way to solve health problems. I will not elaborate on which one. Some of you may know historically how he has actually announced some of the interventions, Mom Connect and others, to try and find health-related solutions. So I want to, Minister, take this opportunity to say, yes, partnerships work. Partnerships with private sector, with civil society. We've seen it with Vodacom. We've also seen it with MSH, that we can really make partnerships work. On that note, I would like to invite the Minister to address us. Thank you.
Thank you. You may get seated. Mr. Vuane Charana, the Chief Executive of Vodacom, the Director General of the Department of Health, Mme Precious Matsuso, Dr. Bada Parasi of Management Sciences for Health, MSH, members of the Vodacom Foundation, and leaders in the Department of Health, members of the media, good morning. Every system has got its identifying features. Now, if you want to understand the identifying features of a well-functioning healthcare system, you may get into the website of the World Health Organization. It will show you that a healthcare system has got 6 building blocks. The first one is leadership and governance of that particular system. The second one is pharmaceuticals and other commodities. How pharmaceuticals and other commodities are supplied within the healthcare system. The third one, of course, is the health workforce. The fourth one, the healthcare financing system, health information system, and lastly, health delivery packages. But today I want to talk about this second one, the pharmaceuticals and other commodities. How do we measure up to it as a Department of Health? As the DG said, it used to worry us that every time we see newspaper headlines about drug stockouts, and sometimes it gives a feeling that there is no medicine in any part of the country. There is a crisis. And most often the headlines are about an impending disaster or a disaster that has already happened. And even though some of them were not 100% accurate, but just the fact that we ran out of stock somewhere and we did not know about it, and it gets picked up by the media because a patient complained, it was worrying us. But in supplying drugs, we obviously need to know the disease pattern of the country. By now we know, because the British Medical Journal, the Lancet, has actually published the findings of the research they had commissioned back in 2009, where they said South Africa is going through a quadruple burden of disease. Putting it in simple language, that South Africans are marching along 4 highways to their graves. And we need to know how to stop those highways. The first and the biggest of those highways is HIV/AIDS and TB. As you know, we have got a huge conference coming next week about this issue of HIV/AIDS and TB as well. That is the biggest highway along which South Africans are marching to their graves. The second is maternal and child mortality. The third is that which we share with the whole world, an explosion of non-communicable diseases that also needs treatment, diseases of lifestyle, hypertension and chronic heart diseases, diabetes mellitus, cancer, and chronic lung diseases like asthma. They are exploding. Now, I am mentioning this because the simple results of that explosion, big HIV/AIDS burden and explosion of non-communicable diseases, is that we have got lots and lots of people who are running to our health facilities looking for help, looking for medication. Just HIV/AIDS alone, only a decade ago, we had 400,000 people who were going to our health facilities looking for ARVs. Now we have got 3.4 million people a decade later, which means logistics of supply, the amounts of supply, etc., will always be found wanting. So then there is a high demand, and all of a sudden we run out of drugs and we are at a loss on what to do. You are aware that there's a civil society group that even had one of their programs called Drug Stock Out, where they were phoning every year and find out what is the level of stock and publishing the results. Even where it was not accurate, we couldn't come out to the public and say, no, this is not accurate, it's a little bit offline, it's a little bit of an exaggeration. These are the true facts. It is with that background that we approach those who we think could offer solution, like the Vodacom Foundation. And as that 2013, it seems like just yesterday. And today we are very proud to say a solution has been found. The DG has mentioned here about the fact that I'm not an IT guru, but I'm very much interested in apps, which is very right. One of the things that interested me, I'm sure many of you know the World Economic Forum, which is held in Davos in January every year. I used to see Minister Trevor Manuel very busy at work organizing for the World Economic Forum. At that time, it had nothing to do with me, or I thought so. But last year, for the first time in the 40-year history of the World Economic Forum, they started inviting ministers of health. So I went to Davos for the first time in my life last year. And this year there were even more ministers of health, because the president of the World Bank, Dr. Yim Jong Kim, said the link between health, good quality health, and economic growth is no longer a debate. It has been made. No part of the world can grow their economy if health systems are not stable. And that's why they cannot discuss economic issues of the world in Davos without health. And that's why they realized they must call ministers of health. Now, last year, one of the things that was discussed is a concept called leapfrogging, that it took close to 100 years for many countries in the developed world, like Europe, to have their health systems where they are. Whether in the developing world, like we are in Africa, are we about to tell our people that they must wait for 100 years before things improve? And give an example of Europe, that no, to move from where they were to arrive where they are today, it took 100 years. And they said, surely nobody has got that time. So we need to leapfrog and jump over many decades, if not centuries, to arrive where most of the world is. And they said 3 methods must be used, like technology. Technology can be used to leapfrog a community or a society or a whole country. The second is new business model, doing things differently from the way you used to do them. Even if you used to do them for that 100 years, you will say, now I'm changing, that's no longer working. And the third is change of behavior of that particular population. So any one of these can leapfrog the whole nation. Now, we needed leapfrogging. And the example of leapfrogging, coincidentally, which was used at the World Economic Forum, is how many underdeveloped countries skipped centuries of development to arrive where the developed world is, with the use of a cell phone. It took most probably 100 years for any country in Britain to bury cables below the ocean, above, and underground, to have a telephone line to each and every family. But within a very short time, every underdeveloped country has arrived there with a cell phone. They can communicate and do almost everything that is done in the developed world. Now, we said, let's use that same phenomena to go over centuries and see if we can arrive where most of the developed countries are. But of course, that gives an impression that when it comes to drug stock out, they've already arrived, which is the common thinking in South Africa. They haven't. Actually, they haven't. I've attended many world fora where this issue of drug stock out or supply is always discussed. It's a big problem around the whole world. Public sector medicine supply chains globally are very much affected by sporadic and even recurring challenges with medicine availability. It's not only in our country where these problems are. I'm also currently chairing the International Board of Stop TB Partnership, and we are very worried globally about the supply of TB drugs, and the Stop TB Partnership even came up with a concept of what is called a global health facility, a facility that has been established to see if we can trace drug stock outs around the whole world. So I'm just saying, we're not the only ones looking for solutions. So Vodacom Foundation came with this stock visibility system, which is being unveiled today. And as it said, we started it in KZN for the simple reason that I said of the 4 highways along which we as South Africans are marching to our death, the biggest is HIV and AIDS, and the biggest prevalence is in KwaZulu-Natal. If most patients there don't get access to ARV drugs, it becomes a crisis. So they started there and then went on to Limpopo, which was also the hardest hit. When I read my budget speech in May, we had covered 60% of the primary healthcare facilities, that means of the clinics of the country. Those who listened to my speech will remember, we said within the next 3 months, we'll have covered the whole country. I'm very proud and excited today to announce that actually we achieved that within 2 months, because the 3 months was somewhere in August. But today we are here, it's not yet August, and we are announcing that we have actually covered all the health facilities, 1,126. It should be noted that this system is only in 8 provinces. That's why we are at 3,126 health facilities instead of 3,500. Because the Western Cape is using a different method, and they said they'll prefer to continue with that method, and they did not rush into the stock visibility system. So it is in 9 provinces minus the Western Cape. But since KwaZulu-Natal and Limpopo started, 605 clinics in KwaZulu-Natal and 478 clinics in Limpopo were completed between 2014 and 2015. In that period, in KwaZulu-Natal, drug stock outs reduced for ARVs by 46%, for TB medicine by 49%, and for vaccines it reduced by 14%. In Limpopo it was even more phenomenal. During the 2015 financial year, ARV stockouts reduced in Limpopo by 66%, TB medicines by 49%, and vaccines by 42%. It is, of course, still too early to tell whether the system is really working for us, but the examples I'm giving, as far as I'm concerned, are very good examples of what the system can do for us. Of course, Dr. Parazi here is going to be presenting to you the system used in hospitals, the RX solution, because the SVS, the stock visibility, is only used in primary healthcare facilities or clinics. Now, ladies and gentlemen, we thought it would be important to unveil the system today for the simple reason that, unexpected to us, there's unprecedented interest in this system, such that we have been asked by the organizers that during next week's International AIDS Society conference, the system must be on display in Durban, and we must be able to explain to other countries, because there is widespread interest, how the system is working. This is not surprising why there will be widespread interest from other countries. Harvard University has organized for the past 3 years leadership courses for ministers of health in Africa, in the Far East, the Caribbean, and South American countries, to try and guide ministers, especially new ones, not Madala boys like me who have been there, new ministers, to orientate them about what they must expect. One of the things they did last year was they can't workshop ministers and lecture them about leadership without understanding the depth of the problems they are faced with in their country. So one of their curiosities of Harvard University was, if you are in Africa or in the, thank you, or in the Far East or in the Caribbean or in Latin America, and you find a country's healthcare system struggling, is it a random happening? Is it a random event, or are there trends? Are there connecting features between countries that are in different continents but happen to be having a struggling healthcare system? So the Harvard Global Health Facility Unit went out to investigate, and last year we were given the results. It was very interesting. They said they found 3 common things among all the countries in different continents whose healthcare systems seem to be struggling. The first one was the issue of human resources, which corresponds with what the World Health Organization has said about the building blocks of the healthcare system, which I've mentioned earlier. They found that problem of human resources. The second one was procurement. This very same thing, issue of drug supply. They found it quite founding in all those countries. And the third one was the whole system of drug supply along the chain. And they said if all those countries can solve these 3 problems, their health systems will markedly improve. So it's not surprising because of that there's a lot of interest in this system, because every country would like to improve their healthcare system. I'm sure you are aware that the new kid on the block of talking about healthcare systems around the globe is improving the quality of healthcare system, especially after the advent of Ebola. We have actually taken a view around the whole world that if we approach the aftermath of Ebola as we did with diseases like HIV, AIDS, polio, malaria, we are in for a very big problem over a long period of time. Meaning what? Putting up a program, a medical program to deal with that specific disease, because you don't know what may come the following day. Because we believe we have arrived in a period in the world where lots of diseases will just follow one another. I thought it was HIV, AIDS, then it was Ebola, Just when we thought we have dealt with Ebola, is Zika, we don't know what's coming tomorrow. And they said the only insurance is not to go around putting up medical programs, but is to improve the quality of the healthcare system, so that whatever comes, the healthcare system can deal with. And we've got reason to believe that something drastic might be coming. Why are we believing so? Number one, climate change. No scientists have actually told us directly, straightforward, that because of climate change, these are a new set of diseases that are coming to the world. We don't know, but we suspect something definitely is coming. Number two, human beings are encroaching on the habitats of other species around the whole world in search for accommodation, in search for economic opportunities, in search for food. We don't know what will unveil when we go around those habitats. New types of diseases might come. And number three, the antimicrobial resistance, whose report is already out, as you know. We don't know, again, what antimicrobial resistance will unleash, but we have already seen signs. So for that reason, we need strong healthcare system. And one of the pillars of that strong healthcare system is to strengthen the pharmaceutical and commodity supply. And we see this SVS coming at the right time for us to do that. And that's why the whole country, the whole world, is interested. And we thought it might look very odd for us to go to Durban and start displaying a system, because before South Africans themselves know about the existence of that system and really understood it. So we thought we should come here and share with you, so that when you go to Durban here at home, you already know that there is something like that. Now, lastly, ladies and gentlemen, we can come with whatever form of leapfrogging, but in the final analysis, the human element. That's why when the World Organization put the 6 building blocks of a healthcare system, they start with leadership and leadership and governance. That's number one, is the human element, because you can, even if you have got the best systems, if the human beings are not prepared to lead or are not prepared to do something, then it won't work. Now, nurses in primary healthcare clinics have got a tool that will help them trace whether they are running out of stock or not. It will also help them to control expiry of medicine, which has always been a problem. Obviously, if you are not able to manage your stock, you have got lots of stock outs. The corollary to that is also expiry, that some of the stock you'll have it in more, in excess than you need, and then it expires. At some stage, I remember, I think it's 3 years ago, we had 14 million rand worth of expired stock in all the 10 depots in the whole country. In 9 provinces, we have got 10 depots. And that was a very painful thing. And obviously, that can easily happen if people cannot follow stock. So I'm trying to say there is a tool. What is left is human will, leadership among those nurses who are leading clinics. One of the things that disturbed me was that when the system started, when people know that we have got a tool, some of the nurses started disliking it because they were saying it's spying on them, It's reporting them to head office, because we were saying no, but we know that you don't have stock in our clinic. You never made an order. Why? The SVS has told us that you ran out of this and that, but we don't see your order here. So next time when clinics run out of stock, we must think first of whether it's just a human element or the healthcare system is failing, or we are failed by that particular one individual who has been given leadership and governance of that particular health facility. So let me leave the rest of the demonstration to those who know and who understand. Me, I'm just happy that there is a system, and I can be able to know before the media knows, as they used to, and then we'll be the one who tells you, rather than the other way around, that there is no stock in that particular clinic. The reason is that the supplier has run out of stock, or internationally, etc. So we'll be giving answers. Thank you very much, ladies and gentlemen.
Thank you, Minister. I think I failed to introduce myself. I'm Maya Makanji, and I'm the Chief Officer for Corporate Affairs for Vodacom, but I also have the pleasure of chairing the Vodacom Foundation. One of the focus areas for the foundation is health. In fact, it's a big focus area for us at the foundation to see how we can transform health systems using technology. The next speaker that I'm going to call upon is Buyani Jahana, who is the Vodacom Business Chief Officer of Corporate Affairs and one of my colleagues on our ExCo. Buyani, over to you.
Thank you very much to the Honorable Minister, the DG of Health, esteemed guests, colleagues, ladies and gentlemen, good morning. Firstly, I must congratulate Maya for a job well done for us. Minister, how we approach innovation at Vodacom, we have what we call social innovation. And we work very closely with the foundation as a sensing area on social issues. And the strategy of the foundation is therefore to find solutions that are scalable, that can do this leapfrogging thing. Once Maya and her team have sensed what needs to be done, then they bring it to us to really start developing the solution. One of the key elements of that strategy is that the solutions must not be bespoke, and those solutions must not necessarily be only dependent on philanthropy. It must allow a bigger ecosystem of partners to come to the party and scale it and actually make it available to a wider society. That's the development model we take in dealing with some of the social challenges. Her leadership in this area has been outstanding for us. We have worked very, very closely in partnership, and we always had the sense that the solutions that she brings to the table are much more focused on dealing with social issues as compared to bigger commercial leverage. And in that way, it's been a great partnership. Much earlier as Vodacom, we understood the power of mobile, that it would be bigger than just communication, voice and data, and leapfrogging, basically building social capital. But it would have a profound impact in key areas of society, in the areas of payments, bring in financial inclusion, in the areas of agriculture, improving productivity of rural farmers and smallholder farmers through integrated value chains, in the areas of education, making sure we can manage schools that are distributed in huge geographies in Africa where IT is non-existent, but also provide relevant content, bridging the gap between the urban and rural, the rich and poor, in terms of access to quality education. And most importantly, the area of healthcare. We saw the leapfrogging aspect that this technology would bring, in Africa in particular, as key. And the fact that healthcare delivery will move from facilities, from doctors' rooms, to where people are, to where patients are, and this tool of mobility would be the primary driver of that transformation. And that would help Africa to leapfrog the development stages that the developed world has had to go through. The minister talked about decades, centuries, and we have the opportunity to leapfrog that. We are on the cusp of technological revolution that is fundamentally changing the way we live, we work, and how governments will deliver services to their citizens. In its scale and scope and the economic opportunity, the transformation will be unlike anything humankind has ever experienced before. As it unfolds, one thing is clear to us, that the response must be integrated and comprehensive. It must be involving all stakeholders, from public and private sector, from academia and civil society. And this kind of partnership we're witnessing today is a result of that combination. The government, the Department of Health, social innovations through the foundation's insights, technology leverage through the scale that Vodacom brings in. We have come up with a solution that deals with some of the critical challenges that are fundamental for the delivery of healthcare to South Africans. Minister, today we are witnessing the results of such collaboration and partnership, and I've just outlined above where forward-thinking organizations have identified social challenge and commit to work together to deliver a sustainable solution. As Maya indicated earlier on, your challenge to us to be innovative in developing a system to alleviate the problems of medicine shortages that sought to undermine the progress South Africa is making in delivering healthcare is what set us on a journey to where we are today. To be able to do this, we had to get a unit, we call it mezzanine, dedicated to focus on these innovative solutions. Because as you would know, a big system at times gets crowded by big events, big processes, so we had to put together a small team that's dedicated in delivering solutions. That would be focused, but the mandate was clear to mezzanine. Jacques Tifos is in Ethiopia, is in Kenya, I was with him yesterday. He leads mezzanine. We said to them, develop robust solutions that are scalable, because telecom is about scale. The impact in Africa is when we take something and make it bigger and make it scalable, so that the leapfrog can be meaningful, and if all South Africans and Africans can actually be able to experience the change in their lives as a result of implementation of these technologies. There's the SVS system that has been rolled out in the 3,126 primary healthcare clinics across South Africa is a truly fit-for-purpose system for managing medicine supply chain and contributing to quality healthcare in our country. With this SVS in these clinics in South Africa, stock levels across the facilities in the public healthcare system, primary healthcare system, will be visible, and decisions about stock forecasting, replenishing can be made in near real time. But for the system to function optimally and provide decision support, everyone must use the system, from primary healthcare facility managers to various levels in the hierarchy of medicine supply chain. Everyone must be interested and committed to ensuring that the system delivers the results. The minister has indicated that technology is one aspect. The human factor is very key. All of us have to work in change management, making sure that the efficacy of the system is protected, and therefore the investment that the department has made does give results. From our side, we have no doubt that the system is future-proof. We'll continue to evolve it and continue to support the department as we implement the further developments on the solution itself. Our commitment to your department and those of your peers in the continent, Minister, is to innovate with you to help leapfrog the healthcare challenges facing the continent. At Vodacom, our firm belief is that digital technologies will move healthcare delivery from healthcare facilities and the doctors' rooms to the homes and where citizens are. Your investment in community health worker development creates a critical foundation for this evolution. What is needed is mobile technology to be applied to deliver critical health insights at citizen, family, and community level, so that we can be able to address healthcare challenges this country and the continent faces. I want to thank my team in the public sector. I want to thank Mezzanine, specifically in the healthcare team. And once again, we owe a lot of gratitude to the foundation for the insights, for the commitment, for working with the department to get us to a stage where we have a solution that is scalable, that can be Pan-African and worldwide. Thank you very much.
Thanks very much, Briani. You know, the one story that comes to mind, and I'm sure many of you have seen pictures of this, is where you see a gogo sitting in the sun, or someone sitting in the sun all day waiting for their medication at a clinic, and they get to the front of the queue and there are no medications available. And, you know, those stories really bring to life what the solution can do, because we're talking about a very technical solution. But when I talk to people about explaining about what the solution can do, it's to avoid those kind of situations. Because we all know very well that if she has spent all day and taken time off from whatever else she's doing, she's not going to come back if her medication is not there. And ultimately, her health is going to be compromised, and she may not actually recover from whatever chronic disease she may be experiencing at any point in time. And we think that this solution, and that's where the foundation comes in, where we looked at solutions like this, help build the social business models that we as Vodacom build, because we know that there's a big linkage between what we do as a business and how we can contribute to transforming society at the same time. On that note, I'd like to introduce you to Dr. Anban Pillay, who is the Deputy Director General for Health Regulations and Compliance Management, and he works with the Department of Health nationally and will share with us more details around how we work together on the stock visibility solution. Over to you.
Thank you very much, Maya. Minister DG and colleagues, I'm also very happy that we are at this point today, because one of the challenges, as the Minister said, is that he wants a system that can predict early on medicine availability. He used to always say to us that I don't want to hear about postmortems, because often when there is a stock out in a facility, we investigate and then give him an explanation of why it happened. And he put the challenge to us to say, I want you to find a system that tells us before it happens, because postmortems are not good enough because a patient has died, and there's no point us knowing about it at that point. So if I can just reflect a little bit on how access to medicines is seen in the World Health Organization, just so that we have alignment. Well, one of the 4 pillars of access are firstly rational use. In other words, making sure that the right medicine is available for the right patient at the right time. Secondly, those medicines should be affordable so that those medicines can be procured for patients. Thirdly, there should be sustainable financing around those medicines. And then finally, there needs to be a reliable health and supply chain system in place so that those medicines get to patients at the point at which the patients need them in a particular facility. So that's the context in which we see access to medicines. Now, one of the global challenges is that at facility level, the outcome in order to get medicines to facilities is fairly complex. Remember, it's the drugs are produced in a particular country, or the active pharmaceutical ingredient as it's known. That's usually shipped to another country where it's then formulated, and thereafter it's then transported either into South Africa or it may be formulated in South Africa, packaged, delivered to a warehouse. From a warehouse it'll go to a pharmaceutical depot, and from the depot it may go to a hospital and then eventually to a clinic. So there are a number of challenges in terms of the supply chain and where things could go wrong in that chain. The World Health Assembly in May 2016 of this year identified medicine supplies and availability as a global health challenge, and a resolution by all member states around how we resolve this problem. What is interesting is that in 2015, November, the World Health Organization called a meeting where they wanted to understand what systems are in place in countries to try to deal with this. And we presented our solution around SVS. And we're very interested to see that a number of countries were very interested in the SVS system. Developed countries, including countries like the United States, asking, how could we learn more about the system? Because we ourselves don't have that level of visibility down to the facility to know how much of medicine is there or what's not there, so you can prevent a stock out rather than talking about it after it's actually happened. So what is this SVS system? I think firstly to say it's a mobile application. In other words, it runs off a cell phone, as we know it now. And what happens is that the system is able to electronically communicate medicine availability. Currently what we have is manual systems. People fill in forms where they capture the amount of drug that they have now, the amount of drug that they're going to order, and all of this information is then disseminated upwards from a facility to a district, to a depot, and then eventually to the head office. And you can imagine manual systems in that we have a number of risks in the way that information is transmitted, and consequently medicine availability is affected. So what the system is able to do is record firstly what stock is coming into the system. It's able to record the stock on hand, and then is able to predict the amount of stock that was dispensed out of the system after recording the stock that is lost. And this is for a primary healthcare clinic, so it's easy for a nurse to be able to manage out of a mobile phone. So it uses a mHealth application, and it's a zero-rated channel for those that are interested in the technology around it. And what basically happens is that the camera on the mobile phone is used to scan the barcode. And this is then networked and available on a web portal with geospatial mapping. So in other words, for that particular facility, the information is uploaded. So it's capable of monitoring all medicines, because all medicines in South Africa are barcoded by legislation. And we've started with antiretrovirals, TB drugs, and vaccines as the initial phase. So all of these medicines are scanned by the nurse, and the barcode information is uploaded. The device is able to then recognize that this barcode belongs to this drug, this strength, and this pack size. This information is then stored and then forwarded from the phone onto a central system. And they're able to capture the stock on hand, the stock that is received, any stock that is lost, and also importantly, expiry dates, so that the system is able to identify stock that that's going to expire, so that you could early on then identify how you move the stock to another facility where it can be used, rather than leaving it to expire and then having to lose that stock to destruction. So basically how the cycle works is that first we have a weekly and monthly reminder which comes on the phone to automate functions on all registered facilities to remind them to submit their stock levels, stock received, and stock lost. Then there's a weekly and monthly stock out count. So you use the SBI mobile application to record the stock on hand, the levels that are stock levels, the expired stock, and any stock that's received since the previous submission. So that then is transmitted through decision making to the provincial, district, and sub-district management. So a person at a district, a sub-district level, at provincial level, as well as the depot is able to see that stock. And then you have this timely distribution of stock from the depot, which is able to then see what stock is needed by a particular facility and the quantity that's required. The system is also able to remind people that they should order stock. The system, if the individual forgets to order or for some reason doesn't order, it then it has an escalation protocol. So it says, who is in charge of this facility? An SMS goes to that individual reporting that this facility has not ordered stock and is likely then to run out of these items. And if that person doesn't respond, the protocol escalates all the way up to the head of department in a province or even the MEC on their cell phones. So the minister spoke about this, and I think it's important to recognize that the technology is 20% of the solution, because the technology makes it very easy for somebody in a facility to be able to monitor their stock. What's very important is that there needs to be change management. So people need to be religious and every week record the stock that they have and accurately enter the quantities on the phone. So if they have 20 of a particular item, they enter 20 and they don't enter 80, because the system then will respond to the amounts that are in the system. And there needs to be accountability for how people actually capture this information. And where people fail to enter the information or enter the incorrect information, management then needs to respond to that, to be able to support them or be able to understand why it is that incorrect information is entering the system. So basically what happens is that the individual enters information onto the system then captures that information and forwards it on, and from that we're able to have dashboards. So sitting in Pretoria, we're able to then identify in a particular facility what stock they have. So if a patient calls up and says that they didn't get stock of a particular medicine in the facility, we would be able to check through the system whether there was stock in that facility or if there wasn't, and what happened. Why is it that that patient didn't get stock yet? There is stock sitting in that facility according to our system. So what are some of the aims and objectives of the system? Well, firstly, it enables visibility and medicine availability. Visibility in real time, in other words, you can check right now in a particular facility, as opposed to manual reports that we currently get. And it also allows for real-time dissemination of information. In other words, it reports information all the way through the chain. So it's not as if when the information is submitted from the clinic to the district office, that only the district office has sight of this information. All of us through the chain are able to have sight into the system. It also then improves communication between the different levels. So if there's a problem at a particular level, all of us in the system are then able to intervene and identify what that is, so that we can have rapid bilateral dissemination of information. So say, for example, there's a shortage of a particular drug like we had last year with Illuvia. By using this system, we're able to then say, okay, a particular facility has maybe only 20 patients, but they're sitting with 60 units of the drug. Another facility has less and they have more patients. So let's move some stock from facility A to facility B in the case of a shortage. So we're able to do that because we have that level of visibility to be able to do that. So this is just a screenshot of what the system is able to do. So on a laptop or a computer, we would be able to get a heat map that's able to show us every facility, and in that facility, what the level of stock is. And Kulani is going to give you a real demonstration of how the different icons work. But basically what you see is a heat map where you can click on any one, which is a particular facility, and it will tell you in that facility that they have all the stock. The yellow would be a facility where they're going to run out of stock, and the red is where they run out of particular item, and intervention is required immediately in such a case. So in terms of the deployment, we have deployed the system now across the country in the 8 provinces, as Minister has mentioned. From KwaZulu-Natal, we went to Limpopo. Thereafter, it was the Eastern Cape, the Free State, Northwest, and Mpumalanga, Gauteng, and Northern Cape. So in total, there are 3,126 devices that have been distributed. Staff in these facilities have been trained on how to use the device. We do recognize that there will be challenges with technology because people may forget, so we may need to go back and support them where they have challenges, where they may forget how to use a particular function. So over time, we think that the use of the device will improve. But currently all 3,126 facilities have the device and are able to use it because they have been trained. So just to summarize what the reporting capabilities of the system are. Firstly, medicine availability reports. So by line item, it will tell you drug X is available in the facility in this milligram, in this pack size, at every facility. It also generates a stock out report. So it's able to tell you that there's no stock of this particular item in a facility, so that it's able to alert everyone to where there's problems. And then there's a stock out heat map. So you can dial into the map, and Kulani is going to show you that, how the heat map works and what information you can get from it. It also gives you signals of short-dated stock. So any stock that's less than 3 months, it gives you a warning that your stock is running out, your expiry date on the stock is less than 3 months. So it may be better to transfer that stock to another facility, may have higher use of that stock because maybe you have too much of the stock. And then also, in addition to understocking, it also reports overstocking, which is also an important area, as the Minister was saying. The number of facilities where sometimes they order too much of the stock and keep that stock and don't return it back so that somebody else can actually have access to it, and the consequence of which is that there is obviously destruction and loss of that stock, which is wasteful expenditure. So thank you very much. I think my colleague will deal with the RX solution after this.
Thank you, Dr. Pillay. I think I'll call upon Dr. Parazi to come in and share about the RX solution, because as was mentioned, there's a slightly different solution in some of the hospitals, that complements what's been done already.
Good day, Minister, DG, esteemed guests, colleagues. It's my pleasure to be here with you today and take you briefly through what RX Solution is all about. I need to make a disclaimer first. Dr. Anman Pillay was about to congratulate me after he heard the Minister call me Dr. Parazi. Now, before I incur the wrath of the hawks, I need to make that correction. No doctorate has been conferred on me yet. Chances are that it will not be because I have not enrolled for one. And then DG, the name SIAPS, Systems for Improved Access to Pharmaceuticals and Services, is the name of the project awarded to MSH by USAID. When it ends in September, MSH will still be there. Thank you very much. And before I get into my speech, I'd like to congratulate Vodacom on a job very well done through this SVS. Now, I will just give an overview of RX Solution, its history, background, exactly what benefits people who use it derive from using it. And then I will go into a further application that was developed by MSH in order to ensure that data gets to the National Department of Health on stock availability. And once I'm done, I will then formally hand over the source code for RX Solution to the Minister. Now, RX Solution was developed in the Eastern Cape when MSH was running a project known as the Equity Project. And pharmacists were just tired of all the congestion through the paperwork that they had to do. And through subsequent projects that were managed by MSH, such as RPM Plus, SPS, and so on, it was perfected. And the objective here really is to support efficient and effective management and distribution of medicines from the supplier to the patient to complete the medicine supply management cycle. RX Solution itself is an integrated computerized pharmaceutical management system, and these are the uses that RX Solution can be applied for. In the pharmacy, the pharmacists are able to manage stock, their inventory. It also allows them with an early warning system when they're about to run out of stock or even when medicines are about to expire. It also enables them to manage the dispensing of medicines. I recall that about 3 years ago, there was a report in the Daily Dispatch in the Eastern Cape of people complaining about how long they had to wait for their medicines. And then 2 years later, last year, the same reporter from the same newspaper went back to that facility. And they were surprised just how quickly the pharmacy managed to get patients to get their medicines and go away. What wasn't clear to the patients or to the reporter was that it was as a result of the facility using RX Solution to dispense. So one of its uses and one of its benefits is that it allows patients to get into the hospital, get their medicines, and go home quickly. And these are some of the benefits of RX Solution. It allows for improved access to medicines through effective stock management and control in the facility. It prevents wastage of stock. It encourages rational use of medicines because as a result of the reports that the system is able to generate, the pharmacist and the hospital management have a tool that gives them warnings as to what medicines are overused and what are the medicines that are very, very expensive. It also allows for an analysis of your medicines into categories such as the nice to have and the very essential medicines. And that way the pharmacist is able to, when they make the preparations for the next cycle of ordering, to concentrate on those medicines that have benefit but are not too expensive. It helps with increased accountability, and there's also increased financial performance because it allows you to know exactly how much you are spending on every category of medicine. It's easy to implement and it's easy to have it interface with any system that's existent in the hospital. Now this screenshot, it's not a screenshot as such, but the donut chart simply gives the percentage of facilities in every of the 8 hospitals where RX Solution is deployed. Most of the facilities where you see the green, most of the facilities happen to be in, so I can't see, 34% I think that's the Northwest Province, 30% in the Eastern Cape, and 24% in the Free State, and so on and so forth. And this on the right gives you just a view of the facilities where RX Solution is deployed. Now, all in all, we have RX installed in 445 facilities. 242 of those are hospitals and community health centers. We still have another 200 hospitals in the public sector where RX Solution needs to be installed. Now, we figured that it would take a team of about 12 implementers, which is the current team that we have, to cover the remaining 200 hospitals in roughly 18 to 24 months. Then we have what we colloquially refer to as the Hospital Surveillance Dashboard, and that's the National Surveillance Center for stock availability at hospital level. We base this system on 3 sets of indicators. The first set on the left are medicines availability indicators that give you an idea of the percentage of stock that's available, percentage of line items that are out of stock, number of vital items out of stock, and number of items out of stock where no order has been prepared. Then you have the set of indicators that give you an idea of how the finances are managed, because it gives you a value of stock on hand, and it gives you a cumulative pharmaceutical expenditure against the budget. So as the year goes on, the pharmacy or the hospital is able to see how far they are in terms of their budget, what's left of the budget for their drug supply. And then, of course, an early warning system for medicines at risk that gives you the number of line items at risk of going out of stock. Now, these are screenshots that you will see on the dashboard. The first one, based on availability, gives you the percentage of medicines that are available. We categorize them into 3 using different color coding. Green means that you have availability of over 90%. Amber means you have between 80% and 90%. And red means you have below 80%. We decided to go for those very high values because it is really not acceptable to have less than 100% availability is not acceptable. But the reality is that you will always have stock shortages for various reasons, including the shortage of the main ingredient in the country. But to have it below 80% is totally unacceptable. And that's why we opted with the department for those high standards. Oops. Oh, sorry. Sorry, I missed the last slide by mistake. But what we'd like to report is that we have now started connecting hospitals. Thank you. That's right. Connecting hospitals to the national dashboard. We had a target of connecting a number of central hospitals, tertiary hospitals, and regional hospitals to the national dashboard. And I'm happy to say that the September target of connecting facilities to the dashboard has already been reached. Some of the hospitals, of course, do not use RX solution, and we had to come with a way of interfacing between the system that's used in that hospital and RX solution to enable smooth flow of information to the national dashboard. 3 of the hospitals are in the Western Cape, and they don't use RX solution. That is the only province where we don't have RX solution deployed. We have 1 hospital in the Free State that's using a different system, and the 5th one is in KZN. I think that's Nkosi Albert Lutuli. That's on a different system. And that, Minister, DG, and colleagues, is what I had to present on RX solution. My colleague Mark will be sitting outside, and anyone who's interested in seeing how RX solution operates is welcome to approach Mark at his table, and he'll take you through RX solution. Thank you very much. Now, at this stage, I'd like to hand over the source code for RX solution to the Minister. And the reason we're doing this is because projects come and go, and years after MSH have left this country, the Department of Health will be able to continue to derive the benefit of RX solution. In here is the disc and a brochure on RX solution, and Minister, a letter from my CEO to the Minister to thank you very much for giving us the opportunity of working with the Department of Health in South Africa. Thank you. Thanks, Minister.
Thank you.
Thank you very much. I'd like to call upon all the speakers to take a seat there so that if you do have any questions, we could take them now. So Minister, leading with you, and if we could get all the other speakers up on stage, please. And thereafter, we're going to have a demonstration outside. So we've got a table set up, so you'll have the opportunity to see the solution live. As they're taking up their seats, if you could raise your hands and let me know if you have any questions, and I suggest we take 3 questions at a time and then allow the panel to respond. Yes, ma'am. If you could identify yourself, please, that will be useful. Thank you.
This is just for interest's sake, really. Sorry, I'm learning from Bloomberg. How hard is it to add features to these solutions, like the RX solution? Because I was just thinking, if you go to a public doctor and you get a prescription, how hard is it to then get that prescription electronically to the primary health facility or onto the user's, the patient's sort of phone? Would it be hard to add additional features to this, or are we rolling out, are we concentrating on what we have for now?
Thank you. Any other questions? Yes, please.
Hi, I'm Paula Gilbert from IT Web. I've got 2 questions. The first one, you mentioned the types of drugs that are on this. Is it only ARVs and TB medication at the moment, or is it being rolled out to all medications? And then the second one, what is the security in terms of the actual app? Because obviously this is quite a great system for criminals to know how much of any drug you have anywhere. So how secure is the system that it can't get hacked into by people outside of the system? Thanks.
Thanks very much for that question. Any further questions? Well, let's get here's a question on the side.
Thank you. It's Sipo from Tech Auto Group. For now, for me, it takes solution. Find out that solution that a patient can certain medicine, and that medicine with a record that goes with the ID or the name of that individual, so that the same patient can't go to a different hospital to reclaim the same medication. I wanted to find out if that solution, it can be modified, or does it have an option to edit other features on it? Because especially in KZN, we find that the patient go from one hospital to claim the same medication. Thank you.
I think let's get a response on the 3 questions before we move on to any further ones. Not sure, Minister, from your team who would like to take those questions.
They are all not ministerial.
Dr. Pillay, would you like to? Yeah, I think Dr. Vuyani and Dr. Pillay have some responses.
Okay. On the issue relating to the electronic prescriptions, we're currently working on a feature relating to electronic prescriptions, particularly for the chronic medicine dispensing and distribution program. Because where a doctor identifies a patient who must get what we call a repeat prescription, we're now working on a model for the doctor to be able to upload that script onto a system so that we can actually receive that prescription in real time rather than having it to be transmitted manually through the system. So we are working on that, yes.
So I think maybe if I add, the design of the SVS solution is sitting on a platform that is open standard, open architecture, that is designed to carry a number of services on it. So you are able to integrate, for example, what you see in the SVS with what you will see in the community health worker databases, and then you can build modules. So effectively, you can just write modules on it. So it's a common chassis at an integrated level, because we're using platform as a principle, because we're in the platform economy. So it's not verticals that are standalone where you have to do a lot of integration. You can plug modules on it. So the department can engineer it in any other way and have an integrated view. So it's future-proof in a sense towards the flow of other information. From a security point of view, the way from a Vodacom point of view we architect products, the fundamental issues around security. So when you go through the product development life cycle, it's not build a product and then think about security as an overlay. One of the key stages in the development cycle, which is the early stage security protocol related to this. So we run an international cybersecurity center here that looks after the whole network across Africa. We run with it alongside Germany for the Vodafone group. So every day we've got engineers that are sitting here in Midrand watching what's happening across the network. So this particular solution is future-proof from a security point of view. It's an embedded security feature, but most importantly, at a cyber level, we see a lot more things and we've got response mechanisms. So we're quite comfortable from that point of view. But also the hierarchy, it's permissions-based system, even within the department. The department can decide who must see what view, facility level, district level, at the provincial level, so you can have permission system. So there's an embedded security system in it, but also there's features for governance about who can see it, who is allowed to see what.
Okay.
Yes, the last question about whether a patient can move from clinic to clinic collecting the same medicine. Unfortunately, it is happening. It's a big problem for us, and it's going to make no sense once we have got NHI. It's going to cause a very big problem for NHI. So we have to come up with a unique patient identifier. This system won't help you. It just helps you that the stock is there. Whoever comes and say I'm sick and all that, the doctor will give them that stock. If they take that stock, put it at home, go to the next clinic, unfortunately, we won't know. So that's a complete different system. In the 10 NHI pilot districts, we have started installing, it's a patient registration system actually. Every South African is going to be part and parcel of our new patient registration system. Now, we have started it in the NHI pilots. As I'm speaking now, we have just completed 657 clinics in the 10 NHI pilot projects only, where this system is installed. It takes a long time because there's a lot of traveling. The teams that are installing it have to travel lots of kilometers throughout the length and breadth of the country installing it. But they've completed 657 clinics. From April, the 1st of April, they picked up 1,400 clinics where they are busy now, and they are hoping to complete that by the end of this present financial year. They'll have completed an extra 1,500 clinics. Then the remaining will be done in the financial year 2017-18, meaning by the end of by February 2018. I'll be telling you that will never happen again. Any patient that goes within our systems and report that they are sick will tell you that, no, yesterday you went to this hospital and that clinic, this is the medication you got, why are you coming here? It also helps us on other social issues. Quite a number of HIV positive patients, when they test positive, they don't believe it. They run to the next institution to see if the results will be the same and keep on hoping that one day they'll get a negative report and say they are free of HIV. We are not able to identify that up to the present moment. So the system that we are putting is not only going to help us on drugs, it's also going to help us know which patient has gone to what facility, but also the history of that particular patient. Thank you.
This could be a bit embarrassing because the minister doesn't seem to know about it. But a while ago, we were approached by the city of Tshwane, and together with the system used by another company, we did an interface between that and RX solution. And as a result, patients, it's a fingerprint identification system that allows the facility to know that this patient has been to collect medicine. What was happening is that patients were going from clinic to clinic to get ARVs. Now, if you go to the first clinic, you go to the second one, the system will identify you as having already received your medication from another clinic. But we've installed it in 4 clinics only, and I think it was due to a lack of budget that they couldn't roll it out to all their clinics.
No. Actually, I know about it. Yes, I definitely know about it. But it's a system for Tshwane. We want a system for the whole country. Because NHI is national, it's not for one. In fact, we have discussed with Tshwane about that because it's on a small scale only for Tshwane. Now, when you get a unique patient identifier for everybody, especially for national health insurance, it has to be the whole country must use one system. In fact, because they are busy loading patients onto it, we had actually said when we have covered 3 million patients in the country, we'll launch it officially. We have just postponed. We could have launched it because they are very far. But Tshwane cannot use a system that differs from the rest of the country, because then it doesn't help us on what you want to do on a national system, on scale. May I also say it also helps us to trace HIV and AIDS patients. We have got 3.4 million patients on treatment. If any one of them dies or changes a province, it's difficult for us to know whether this person is just no longer complying, is left treatment, or he has passed on, or he has changed from one province to the other. It's a struggle we know after a long time. So that system will make us know immediately. So the Tshwane one, we knew it, we respected it, and we warned them. That thank you very much for doing that for Tshwane now, but we have got to join the rest of the country.
Thanks for the clarification, Minister. Dr. Pillay, did you have a comment?
Yeah, I think the other question was which drugs will the system use? So what we did is we started first with antiretrovirals, with TB drugs and vaccines. And once this clinic gets that right in terms of getting the system going, then all other drugs it'll be expanded to every other drug that the clinic is supposed to keep. Yeah.
Thank you. Are there any further questions? The lady at the back there.
Good day to everyone. My name is Neliswa from SAPC Radio. I'm just curious, how much is it costing the government to actually implement the system? And in terms of expanding the system as to which medications are to be allocated using this system, or which other medicines are going to be prioritized? As you've mentioned that TB and HIV/AIDS medicines are currently underused in this system.
Okay.
Also, last question. With regards to, you're saying that the system is already being implemented at some of the clinics. What's the next step in terms of actually using the system in hospitals? Because also hospitals do experience the same problem of drug stockouts. I don't know if it's related to the concept of RSX. If you can just elaborate for us.
Okay.
Thank you.
Okay, perhaps let me answer the first question and say that it's such an opportunity that we had, and like we said, because this was a partnership in the first phases of this project when we're still piloting, and thanks to the Vodacom Foundation, they actually sponsored the implementation. When it started in KZN, in Limpopo, Eastern Cape. So we said that we can't just stop with 3 provinces. And we then, with the support of development partners, expanded to the rest of the country, excluding Western Cape. So it actually has been probably the most affordable option. As you know, the tools that are used have been basically Vodacom tools, and maybe they can tell you how much they spent on their side, but for us it's a donation and we love it. But perhaps your question is long term, what will it cost? Now, because we're working on an integrated kind of approach, the minister was explaining that we actually have a much broader platform in preparation for implementation of national health insurance. And this is a patient registration system that we're rolling out across the whole country. And this is based on our e-health strategy and our m-health strategy. And both those strategies have been implemented so that we can ensure that there's connectivity between multiple systems, whether m-based or computer-based systems and so on. So we are working in partnership with the various partners to do that. And we're looking, we did the first phase at primary health care to look at all the systems that are used at primary health care in both the public and private sector. And out of those, we shortlisted about 22 of them that met our interoperability criteria. And what we did, we then looked at what the cost was. And just for your information, when we did this exercise, we actually identified that a few of those systems still operated on DOS, and some of you may not even remember DOS, and others on WordPerfect. Some of you may not have been born when we used WordPerfect. So we did away with those. Actually, we got rid of those that were based on, archaic systems. So we're at a stage where we started the hospital process, because the hospital systems are quite complex. And from a modular approach, you have a system that's used in theater, another one in ICU, a system for radiology, for pathology. So what we did, we said we're going to follow the same process based on a normative approach, assess whether they were interoperable, whether they were, the security features were in place and so on. So that exercise is underway, but we're engaging all partners, both in the public and private sector.
Thank you.
With regard to RX Solution, now RX Solution was developed by MSH, but funded by the United States government through USAID. No one can therefore charge any license fee. We know that software systems cost millions in license fees. So it is really going to be used by the South African government without the payment of any license fee. And anyone else, long after MSH has exited, who charges a license fee for that, ought not to do it.
So perhaps for your other questions, the first one, I think the second question was about whether this system is for all medicines. I think Dr. Pillay, in his explanation, was sort of trying to outline how we followed the process of including different medicines. We prioritized HIV/AIDS, TB, and vaccines, but we have all medicines that are on the essential medicines list on the system. So I thought we needed to clarify that it's all medicines that are on the essential medicines that the government procures. I thought I needed to clarify that.
Yes, thanks to DG. I'm not sure whether the SABC team was answered. I suspect they arrived late. Yes, the SVS system is for primary health care clinics. That's the stock visibility system. For the hospitals, it's the RX solution. Now, all the clinics in the country that needed the system, in all 8 provinces, I told you Western Cape was using a different system, have been covered, meaning all the clinics. The RX solution has just covered 242 hospitals. We've got about 350, which means about 100 are still going to go on the RX solution. That's why they need about between 18 and 24 months to complete all the hospitals. But the other 242 hospitals are already having it. On the issue of cost, I think the DG and Pada has also explained. We can't be charged. It was given to me. It's ours now. The reason that they called me there in front and I stood for quite a few minutes to receive it. I wanted you to capture it as evidence in court that this thing was given to us. Nobody can charge. It's ours now. It's our property. The issue of IP is our intellectual property, because intellectual property has got a very big problem in accessing healthcare. So you have captured it on camera. It's evidence. It's our system. It belongs to nobody else. The issue of affordability again. One of the things I didn't mention about leapfrogging, as it was discussed at Davos, the World Economic Forum, was, can you leapfrog everything? In other words, can you leapfrog every system? They said, yes, you might, but whether it's an advantage or not, that's another story. So for a system to be leapfroggable, or for you to say this system has got advantage of being leapfrogged, it must have 3 identifying features. Number 1, time. It must be done within a short space of time. No point in waiting for many years and say we have got a new innovation. And the SVS, as I told you, we agreed in May that will cover all facilities, and we did it in July, which means it passes that particular feature of time. The second feature is scalability. Can you do it on a mass scale? That's why the Tswane system is only for Tswane. Small. It needs to be on a mass scale, and that's why it's done to every single clinic regardless of where it is. So it has also passed the master of scalability. The last one is affordability. There's no point in coming with a new innovation which your country cannot afford. So it must be afforded. So once it can be done within a short space of time, once it can be done on scale or massified, once it's affordable, then that system can be leapfrogged. And the SVS has passed all 3 of them. If it passed only 2 and affordability test it didn't pass, we wouldn't have taken it. Because how are we going to pay for it? Thank you.
Thank you, Minister. I think the Minister has answered the question, because one of the key things when you look at social innovation is exactly this. Can mobile help leapfrog, scale, affordability, and timeliness? The Minister has outlined this. And keep in mind that a lot of what you do on mobile, we're looking at what is natively in the environment. So mobile, people use mobile for many things. They use mobile to phone, they use mobile to recharge, to go into the internet. So the training, the learning curve is killed completely. So the cost of adoption is lower because you're using a device that's already there. Ordinarily, if you go to a facility and want to scan, you put scanners and all that. But you're using embedded services, device features on the device that you use for camera, but you change it to be a barcode scanner, which means there's no challenge in terms of length. So there are a lot of adoption and training and related costs. There's no new IT system that must go in. You're using the very same network that is being used for open internet. So all those features, they help make this really transformational. And that's why also we said foundation will come in and help to really put belief or put a lot more focus on our belief that the solution is very transformational. And I think, Minister, it passes all the boxes.
Yes. May I add, especially on the issue of affordability, if you read the white paper on NHI, one of the features is also affordability. I'm saying this deliberately because there are people who are strong critics of NHI, and they are telling the country that it's not going to be affordable. And we are arguing very strongly that the feature of affordability is one of the strong features in the system. That's why we applied it even to this one. And we do not agree with them when they say NHI is going to be an unaffordable system, because they are calculating using the present platform of healthcare system, which we are definitely going to change and make sure that affordability is one of the central features. And I'm repeating, no point coming with any new innovation which cannot be afforded by the citizens or your country. So in everything that we are going to apply in line with the white paper on NHI is a central issue of affordability. Same as ARVs. I'm asked that question every time when we keep on saying we are going to put more and more people. I keep on being asked about the question of affordability. I'm sure you notice now. Even now they are asking me, we are starting test and treat in September. The first question, is it affordable, Minister? Forgetting that in 2009, when we launched the massive ARV program, I was asked whether it's going to be affordable. We've got 3.4 million people on ARVs today. Very much affordable, because by 2002, to put one patient on ARVs, it used to cost 10,000 rand per annum. Now it's 1,700. We use every method available to make things affordable. Same as HPV vaccine. Just because one dose of that vaccine is 1,000 rand, and young girls who need that vaccine need 2 doses, it means it's 2,000 rand per learner, because we are doing it at schools. Now we've vaccinated 700, not 2. 700,000 learners. If you follow that reasoning, which is used by the critics of NHI, we'll be needing 1.4 billion rand. But do you know how much we're paying? 200 million only. Because because scale and affordability. And so we're vaccinating school girls, 700,000 of them for 200 million, not for 1.4 billion, which will have been done, which will have been the case if we calculate it according to what's happening now in private healthcare sector. So I'm just giving that examples also to show that we're not going to follow their methods when we implement NHI. We're going to make sure that affordability is one of the features that must be passed. And so this particular system has passed that, and we are very satisfied about it. Thank you.
Any further questions? Let's take one last question. Yeah?
We talked about scalability a bit. I'm just wondering, are you considering also talking to other governments where you guys are operating in Africa currently?
We actually are working with the CSIR. In fact, from the beginning, we engaged a CSIR and HISP to bring in skills, because we are not experts in health. What they did, they developed standards, because remember, over the past 20 years, we spent quite a lot of money in the health sector developing health information systems. I think we spent over 4 billion, but we still did not have credible information systems that gave us intelligence, that helped us with planning, that helped us actually with patient information systems, and including the electronic record that the minister referred to. And as part of that, we thought that we needed to follow a normative approach. And it's for that reason that we came up with norms and standards, so that we can assess all systems that are available in the country. It's sometimes difficult when you just take something off the shelf and it cannot be used in your own settings. So the normative approach that we followed has been quite useful, because we're able to assess all these systems that are currently available in both the public and private sector. And it's on those grounds that we've been able to start this process at primary healthcare level. So we are working with the Department of Science and Technology and CSIR.
Perhaps, Vianney, you can also share some of the work we're doing with similar solutions in Mozambique, Tanzania, etc.
Or maybe before, I was going to add to say that we also are currently involved in a project with Vodacom Foundation again. You may have heard, or you'll probably hear even more, about community health workers. There's a massive program on community health workers that we're doing with Vodacom. It's probably an innovative a system that they've developed, and it's quite good, and the minister is quite passionate about it. But also, I think, Minister, if I may, with your permission, we launched apps, multiple apps. One on, a Mom Connect for pregnant women, and one for youth, for adolescent and youth health. And we've got some that are actually that you can download. These are specifically for clinicians. We don't want doctors carrying heavy guidelines, in their bags. They can just get them on their apps. HIV/AIDS guidelines and multiple other guidelines. So we actually using innovation for various reasons.
Thanks a lot. I think just to cover, the solution already we have implemented in Tanzania, we've implemented in Mozambique in terms of tracking vaccines. One of the key things, talking about scale and mass, the solution can operate off Vodacom footprint. The past 2 days I was in Ethiopia. We're discussing with the health department in Ethiopia around this. So it can operate across the globe because it's an IT platform that can operate on any kind of SIM card. So we think that using lessons here in South Africa, we found a formula that will transform healthcare in Africa and in the developing world. And the good thing is that it's developed with deep understanding of the environment and challenges that are facing the African continent. So there is uniqueness in there, and we want to bring it to scale. So whether we have an operation or not, we can deliver that. Thank you.
I'm aware that the Minister is under time pressure, so he does have to leave right now. However, we'll do the demonstration as soon as he's left, and that will be followed by lunch. So we'll have the demonstration now, but let's allow the Minister to leave.
Thank you, everyone. I'm just going to be quickly taking you through the overview. Okay, sorry, I need to be on the mic. Thank you, everyone. I'm just going to quickly take you through an overview of what the facility have to do in terms of updating their stock using the stock visibility system. So each and every facility that they were referring to, the 3,000 facilities, are deployed with a mobile device, and the mobile device come with an application called apologies on that. As you see, it's NDOH SVS. So they can go into NDOH SVS. On NDOH SVS, they will find their facility details, which is their clinic name. So each and every clinic is assigned a mobile device that is already assigned to their clinic and their clinic profile and wherever the clinic is situated. So they can go into the main menu. From the main menu, they can record their stock level. Recording their stock, this is the most important, crucial item that we actually train them on when we do training for the facility level, for the people that are going to be doing the stock taking at the facility or at the clinic. With the record stock level, they can record their stock level using different options. They can scan a barcode, or they can use a manual option of selecting single stock item from the drop down. So I can quickly take you through how they can record their stock using the scan barcode option. So they can just select on scan barcode. From the scan barcode, they can just take the medicine box, and then on the medicine box, they can just reflect it on the barcode and the medicine box. Immediately, the application will pick up what the item that the facility just scanned is. And then they can just click on proceed. When you click on proceed, it will give you a history of what that item that the facility just scanned is. So as you see there, if the application or if the facility has updated an item before, you will see the history of an update of the particular item. So what we see on the screen, the facility that we're using to demonstrate didn't do any update on that particular item. Then they can just scroll down, and then with whatever is available on their medicine room, they can just input the number. For an example, if the stock item for that particular item is sitting on 20, they can just type in 20. And on the expiry date, this is one of the most important features that we also take into or monitor. They need to enter the nearest expiry date of the item. So we do take into consideration that the facility might have many boxes of items with different expiry dates, but they need to update the items that have the nearest expiry date. So they can just click on the calendar, and then they can input the expiry date based on what is available or what is indicated on the box of the item. The stock received for the previous week, since the updates happen on a weekly basis. If they have received anything for the past week, or they need to update that input there. So if they've received any stock of that item in the last 7 days, they need to input that item. For an example, if they have received 20 items, the stock lost option. So this is the stock loss due to maybe the items that got into the facilities have expired or lost due to theft. So there are different aspects to the loss of the item when they get to the facility. So if they've lost any items from the 20 batch that they've received, they can just indicate here, and then they can click on proceed. So once they've inputted all those line items, it will give you again the summary. This gives the facility a chance to go back and edit whatever inputs they have inputted on the particular item. So they can go back and edit those particular items using this edit. But if they can see that all what they've inputted based on the particular item is correct, they can just proceed and click on the button accept. In that way, now that particular stock item has been recorded, and it syncs through immediately into the systems where you can view reports of that particular item. That is actually recording an item through scanning of a barcode. The single stock item one, which is the manual one, this one we normally advise them to use it immediately that they discover that a certain item is out of stock. So they can go into single stock item, and then it will ask them to select on the category that they're trying to update on. For an example, if they're updating a TB item, they can quickly select on TB, click on proceed, and then all the TB line items will be populated. Depending on the one that is out of stock and they want to update on, they can select on the TB items for an example, and then they can click on proceed. Once they've clicked on proceed again, it will give you a summary if you've done an update on the particular item as indicated on the previous update, and then they can update the current stock. So this one, for an example, we've got a 0 stock out at the facility. The facility doesn't have that TB item at all. So because there's no TB item, the expiry date, we don't know the expiry date. The stock received, we haven't received anything, hence we're sitting on 0. Stock lost, we haven't lost anything. Then you can click on proceed. When you click on proceed, there's a series of questions because we also need to address this, or the management need to look at the flow as to what is the cost of the stock out in the particular facility. The first question is, have you placed an order? Since you're experiencing a 0 stock out on that particular item, have you placed an order? Then they can indicate, yes, maybe we've placed an order, and then proceed. The next item will be, or the next question will be, what is your stock out reason? Are you out of stock because maybe you're waiting for the order that you've placed, or are you out of stock because your nearest depot indicated to you at a facility that they don't have the particular item, or is your supply out of stock? Because we understand that the different items are supplied by different suppliers. So For an example, they can indicate that they're waiting for a particular order, and then they can click on proceed. The next question is, we do take into consideration that certain items can be out of stock, but there's an alternative medication or pack size for that particular item. So we do ask them that the item that you're experiencing out of stock is on, do you have an alternative pack size or an alternative supplier on it? If they do, they can say, yes, we do have an alternative pack size, and then they proceed. Once they proceed, all those updates again, you can get a summary of it before you click on accept. You can get a summary of it where you can go back and edit. If we see there below, your stock out status is yellow. Your stock out status is yellow at this point because you said you've got an alternative at that product. If you were out of stock and there was no alternative at all, your stock out status was going to be red. And then you click on accept. So this is basically how they do stock updates using the SBS application at a facility level on a weekly basis. So once everything is captured, there is a web portal. There is a web portal that all the managerial level can log into and view the different reports based on what the facility has updated. So this is one of the stock out heat map that they were referring to in the previous presentations. So this is dummy data that we work on the Vodacom premises that we use to test that whatever that the Department of Health requires is up to date. So what you see here, the facilities that you see here are all dummy facilities that we use to test our system on a daily basis to ensure that we meet all the requirements for the Department of Health. So what you see here is a stock out heat map that they were referring to. So after capturing, the data syncs through immediately, and from a different level, you can log in if you've got access to the system. From a national, provincial, district, and a sub-district level. When you log in, you can view different reports. One of the reports, for an example, this report, based on what we were capturing, the different flaggings, we've got the yellow, the green, the red, and the blue. The different flaggings of each facility will represent the status of the facility in terms of stock. So for an example, the red will indicate that that particular facility in your province is running out of stock. So meaning there's items that are on zero. And a yellow, meaning that that particular facility, it has a stock out, but however, it has an alternative pack, like I've showed you in the application. And the last item, the blue one, when your facility is blue, meaning that this particular facility has run out of stock of particular items for more than 21 days, because we do take into consideration that more than a week or more than 14 days, then we need to do necessary flagging so that the different managerial areas can take action into the stock out. And then the last one, the green, meaning that particular facility hasn't reported a stock out in the previous week. So for an example, on a click of a certain facility, this will give you all the items that that particular facility has indicated that they're out of stock on. This will help in a managerial side for each line item, that you can see that for each line item, it will tell you the current stock, what was recorded by that particular facility, how many items that that facility have, and then from there, what items were not submitted by that facility so that you can take action and get them to report on that particular item. So in high level, there's many reports in the system. When you log in, you can view the current stock level, what is expiring sooner, and what has been out of stock for this amount of days, and what is about to expire, as I've indicated, and when was the first time the stock out was reported by that particular facility. This can be done per facility and per line item in the reports. I thank you.
All right. Afternoon, guys. So RX Solution, it's a very complicated, very detailed system. So what I'm going to do is I'm going to give you a very brief overview of what it does. So right at the beginning, this is our home screen. Every user will have a username and password. Once you've logged in onto the system, every single click of the button is recorded. So you can trace whatever has been done, how long the user's been logged on for, etc., etc. Just a bit of background about a pharmaceutical process in a hospital facility. You'll have the main store of the hospital, which will supply its demanders, be it the pharmacy, the inpatient pharmacy, the outpatient pharmacy, the wards, the supporting clinics, etc. That main pharmacy, main store, will place an order to the depot or to a direct delivery supplier. The stock will come into the main store, and then it's going to be issued to one of the demanders. All right, and RX Solution tracks this process. So when you place an order, you're placing an order from the main store. So when we do a process on this order button here, we're placing an order from the main store of the pharmacy to the supplier, be it the depot or a manufacturer. Once the depot has delivered the stock, we're going to go through the receipt process. And then when the main store goes and issues the stock to the demander, it's called a requisition on the system. Once the requisition has been done, it moves from closed stock or from the main bulk store to an open stock facility where that is where you're going to be dispensing to the patient. All right. An RX Solution, it records a batch number and expiry date at the bulk store, as that's where majority of the stock will be accounted for. Once it moves over to the open stock facility, it just records the number as then it issues to the patient. So you can record from the bulk store to the supplier, supplier to the bulk store to the demander, and then from the demander it can do a dispensing to the patient. So you can track the whole process of the drug. Okay, so that I've just made a whole bunch of dummy information over here. So we've got the suppliers, I've just created a supplier name, and the demanders, I've just created two demanders. So if we go through the process of the ordering, let me show you this part first. So this is now the stock at the bulk store level, right? So again, I've only created a little bit of stuff here. You can put drugs into certain bins and certain filters. So you can see I've put amoxicillin into a liquid bin. Okay. You can currently see at the bulk store level we have a 350 bottles of 100 mils in stock. I've put a filter of it as an antibiotic. And the group 2 means it's another ordering filter, so it's being filtered to the PMPU. I currently have on the system 100 on order, so you can track all your outstanding orders, and currently nothing on hold. What on hold means that it's been reserved for a certain demander, so you can't go and issue it out to another demander because it's already been reserved for that demander. And then we've got the min and max levels. So you can see currently for efavirenz, I've got 1,200 on hand. I got 100 on hold, but my min is 800 and my max is 1,200. So you can see I'm already stocked up fully on that drug. If we go and we take a look at this one, for example, ibuprofen, the minimum is 950 and the max is 1100. So you can see this system will then auto-generate an order for this product as it's below the minimum, and it will replenish it up to the maximum level. So for this example, it should order 180, 180 packs of 15s. So if we go, I'm just going to take you through what I've done already. If we go and we click on one of the orders, you can see it tracks the supplier name, the account, on what budget it's coming from. You can have multiple accounts, and then who ordered it, who authorized it, and then the voucher number. So you just go and you say tenofovir, you got your in-stock value, you got your on order, your min and max, so you can make an informed decision right away just from the screen on how much you want to order and if you want to adjust the order. And once you've posted it, you send it off to the depot however it wants. We have integrated with a system called RDM, which you can export a file, import it into RDM, and it sends it straight to the depot. So that's the ordering process. Once the depot has processed the order, you can come back into the receipts. And you can only receive a product if you've placed an order on it, on RX Solution for that product. So you select the order reference number, and then the supplier name in the account comes up automatically. You put in who received it and who checked it, and you put in the quantity that you've received with a batch number and expiry date and the price if it's been changed. Once that is being posted, the stock then moves away from your on order column, your on order over here, and goes to your on hand column over here. When we now want to issue it to the demanders, we go to the requisition side, and you can see you select the demander, you select an account, who requested it at the demander level, who authorized it at the demander level, who issued it at the store level, and then who received it again at the facility level, at the demand. So you can see issued to Nofover, I had 1,460 available. They requested 100 and I issued 100 with that batch number and that expiry date and that price. So then it moves from the on-hand column and then it will go into the demander's stock levels. So you can see I've done some processing here already for this demander. And you've got amoxicillin, I've got a pack on hand of 149, and so on and so forth. This negative over here, RX Solution is very malleable, if you want to call it that, where if a facility only wants to do dispensing, the system allows you to do dispensing, and that is where the negative figure comes in. So it allows the facility not to do any stock management if they don't need to, and they just want to use the system for the dispensing side. It does, however, warn you that the stock is going below zero. With all of this information, I mean, there's a lot more. There's stock taking that can be done. You can return stock to a supplier, return stock from a demander. You can do pre-packing, so that's pre-packing from a pack of thousands ibuprofens to packs of 15s, and it prints you the label for you with a new batch number and expiry date and so on and so forth. Demander transferring, that's transferring from one demander to another, so it's not coming back into the main store, it's going from one open stock to another open stock. So OPD is out of stock of Panado, but inpatients has it, so you can just transfer the stock over. And then a demander stock taking, that's the open stock taking. I forgot to mention, at an open stock level, it also records per tablet. We call it the smallest known unit. So you can record, so you can see over here, we've got -1 pack, but the pack is 28 tablets. I could go and issue 2 more tablets, and it will still say pack -1, but it will say SKU -30. So you can issue per tablet or per ml or per vaccine or however, per dose. Okay. So with all this information, we've also now got the national dashboard where you have this information will automatically get uploaded onto a national dashboard so you can see a nice overview. So I've just created some dummy stuff here. I know it's very not pretty, that was the last minute thing. So you can see these are all the facilities that are currently linked to the national dashboard. Not necessarily all of them are loaded on with RX Solution, but they're all linked on with the dashboard. So you'll get an overview of all the facilities, and then once you clicked on any of the buttons or you searched for a certain facility that you're interested in, you can go and you take this and you click on it, you go into this screen, and it will tell you exactly what drugs broken up by their VEN status. VEN is vital, essential, and non-essential drugs. That all of that information comes from RX Solution at the facility level. And if we go back to RX, it will also do the dispensing side. So we spoke a little bit about how to get a prescription from the hospital to a clinic and making sure that the patient's medication gets there on time. Because of the different levels of care, some certain medication cannot be ordered by the clinic and has to be issued from the hospital to the clinic on a patient name basis. And this system also provides for that. So if we go, I think I created myself as a user, as a patient here. You can search for the patient's information by the surname or however you want to, the first name, the ID number and so on. And it will tell you all the prescriptions that the patient's ever received. Okay. this is the medication history of the patient, and this is the medication that's currently in this prescription. Okay. All right. So from there, the patient's information can be filtered into a down referral system, and then all of that can be printed out. Cool.
Thanks. As you can see, very, very detailed solutions on both the Vodacom solution as well as the RX solution. And both Dr. Pillay and Leon Jarama said if you have any questions, feel free to contact them, whether it's today or offline. Thank you very, very much for joining us today. And please join us for lunch. It's in Floor 500 as you go downstairs. Thanks very much to all the speakers as well. Yeah.